Hi, survivors. Good evening. Thank you for joining our Project Pink Straight Talk. I'm excited to introduce you to two wonderful guests that we have this evening, wonderful experts to speak on hyperbaric oxygen therapy and how it can be beneficial during breast cancer intervention. So before we get the evening rolling, I want to thank our generous Project Pink sponsors and donors. Because of your wonderful support, we're able to offer great educational opportunities like this, along with all our programs free to our breast cancer survivors. So thank you again. My name is Denise Salzbrenner. I'm a thriver who's been blessed to be treated by both of our experts tonight. I was fortunate enough to be able to receive hyperbaric oxygen therapy and really saw a lot of benefits from it. So I'm excited for you to hear from these experts to kind of just discuss what it is and what the benefits are for you. I'm going to introduce you first to Nick. He is on our Zoom tonight. Nick Marsack. He's a nurse manager of the Hyperbaric and Altitude Medicine program at Mayo Clinic in Rochester, Minnesota. He's an advanced certified hyperbaric registered nurse with 17 years of experience in critical care nursing and 10 in hyperbaric medicine. So thank you, Nick, for joining us tonight.
Thank you very much for having me.
And then we also have Dr. Jeffrey Cooper here. He is the director of hyperbaric medicine at Nebraska Medicine. He's a professor of emergency medicine, editor-in-chief, Stat Pearl's knowledge base, undersea, and hyperbaric medicine section. So thank you for being here, Dr. Cooper.
That's a mouthful, isn't
It
it?
is a mouthful.
It's great being here. Thanks for the invitation.
Yes, thank you. It's great to have you. So our straight talk tonight's going to look a little different since we have Nick on our Zoom tonight. But please feel free to submit questions as we go. We're just going to kind of have it be a conversation between both Nick and Dr. Cooper. And then as you have questions, please feel free to ask them, and we'll go ahead and ask them throughout the night. All right, so if we want to get started, Nick, would you like to start us off by sharing some things about hyperbaric oxygen therapy and just kind of explaining what hyperbaric therapy is?
Yeah, so hyperbaric oxygen therapy is what we understand here at our program to be an adjunct to a well-defined and executed medical or surgical care plan. So we are here basically to support the interventions of either a medical team or a surgical team in trying to resolve or bring some improvement in the condition, whereby we're going to use our hyperbaric oxygen to try and improve the condition of the patient. In the context of breast cancer survivors, very often we see patients, and actually it constitutes the largest portion of our patient population coming to see us for the delayed effects of radiation. So again, survive the cancer, but those tissues adjacent to that tumor have now been injured by the radiation, and we get involved in the care of patients to help improve their condition. So perhaps there's further surgical intervention that is warranted, and we can improve the quality of the tissue within that operative field. So it's again, it's an important intervention, but one that really requires a shared care of a patient to make sure that we are actually maximizing the potential outcome based on, again, a really well-defined medical or surgical care plan.
Great. Yeah, I know even with just the radiation for my own self, I know that I received a lot of radiation fibrosis from my radiation. And so I know that was a huge benefit prior to my surgery to have that hyperbaric therapy done as well. So thank you for that.
Sure.
Dr. Cooper, do you have anything to add?
Sure.
Yeah.
I always have something to add.
Awesome. We'd love to hear it.
I completely agree with Nick on kind of how we need to fit in with surgery and oncology in these kind of cases. At Nebraska Medicine, and I would guess probably similar at the Mayo, because they're major cancer centers, a large amount of our routine work is radiation effects, delayed radiation effects, or sometimes known as radionecrosis. And so that thankfully is a relatively rare occurrence. Most people that get radiation therapy don't get severe delayed effects of radiation, but a small percentage do. And because we're doing better with fighting cancer, so even though we're getting better and better with radiation therapy, so that the percentage of patients getting radiation therapy, there's a smaller and smaller percentage of those patients that go on to have severe radionecrosis problems. Nonetheless, we're saving so many more cancer patients that we're actually seeing a lot of complications, if that makes sense kind of statistically, right? So we are seeing a lot, and I would say about 2/3 of our treatments are for radiation effects where we're at. And those effects, those side effects, probably kind of a multifactorial thing, but the radiation probably causes two major things. One is there's kind of a direct effect where you damage the cells of that normal healthy tissue that surrounds a tumor that you're trying to kill. And so you get loss of those cells, and you get like you were saying, like the fibrosis, you get fibrotic changes in that tissue. There's also damage to the vasculature where you lose the normal vascular structure, similar to the microvascular disease you might get in diabetes. You're losing the small blood vessels due to radiation effects. And so the tissue is not getting enough oxygen. And because of that, again, you're kind of starving the cells out for oxygen and nutrition, and you lose the normal cellular structure, and you end up with this kind of fibrotic tissue. So the key to the hyperbaric oxygen is it actually, and it's kind of, I don't want to use the word miracle, but to me it's kind of miraculous, is that oxygen, which we normally breathe for energy as part of our metabolism, under high pressure acts as a drug. So it acts in this hitherto unknown way where it acts as a drug and actually stimulates the growth of new blood vessels, as well as the recruitment of stem cells into that area that's not getting enough oxygen, and starts to repopulate the area both with blood vessels as well as stem cells to improve the tissue quality. And that, over time, is what causes the beneficial effect. I think sometimes people have the mistaken idea that there's not getting enough oxygen, so we're going to give you more oxygen. And that's not really it. It's really that repair of the damage and that reversing of that process that allows then the body to heal itself.
Awesome. Yeah, that's great. That is great. So can you explain to our audience, because I don't know if they're all familiar with what exactly it looks like when you get hyperbaric oxygen therapy?
Yeah, sure. So it can look, I guess it can look like whatever kind of chamber you want it to be, but we have the small chambers that are about the size of a bed. Kind of looks like a tanning booth, right? A tanning bed. But it's just a cylinder. Ours are clear plastic, and we fill them with oxygen, and we pump that pressure up to 2 to 3 times normal air pressure, which is about the equivalent of 45 to 60 feet of seawater. So like a scuba diver diving down about 60 feet, that's the equivalent pressure that we're using. And they basically are in there for about 2 hours breathing that. I kind of joke that my job's the most boring in the hospital, because we've got these clear plastic chambers. We just stick a TV up so that the patient can watch the TV, and I'm sitting there watching the nurses watch the patients watch TV. So that's my job.
That's great. That's great. Sounds
It's
like
a good gig.
Yeah,
great
yeah,
gig.
it is.
Yes, yes. Nick, did you want to kind of explain what a hyperbaric chamber looks like at Mayo?
Yeah, so the chamber that Dr. Cooper is describing is a monoplace chamber. It's a single occupant chamber. We also have a multiplace chamber. It's a triple lock hyperbaric chamber system, it's basically two large rooms with a smaller room in between. The room is about 10.5 by 19 feet. And it allows us to treat patients with hyperbaric oxygen therapy in aggregate. So we can treat the chamber. Each treatment room is actually rated to administer high flow oxygen to 12 patients simultaneously. We don't have a clinical need to do that, with the exception of something like a mass casualty event with carbon monoxide. But we daily will treat up to 6 lower acuity seated patients in the chamber for a hyperbaric oxygen therapy. And so it administers the exact same therapy that is delivered with a monoplace. The difference is that because the volume of gas is so large in this room, we can't pressurize it with oxygen because that presents a danger. We pressurize it with air, and we use an oxygen delivery device in the form of a hood set, which is basically an oxygen tent for your head. And it delivers high flow oxygen at 100% to the patient under hyperbaric pressure, and it stimulates the same physiologic processes that Dr. Cooper was describing. It just offers us the benefit of treating multiple patients simultaneously. We do have a monoplace chamber just as well. We use it more strategically for, say, after hours, urgent or emergent care. But both have their place in a hyperbaric facility. And we're pretty proud of the one that we have. It's an excellent piece of medical equipment that allows us to do a lot of things. We're very capable because of the chamber system we have.
Yeah, that's awesome. I know when I was getting treated there, and I was in that chamber, that I joked with the hood mask that you talked about, that it's almost like you feel like an astronaut.
Yeah, and we've used it. We've sold it that way. There's been times where we've had to approach a young person, and we sell it as a space helmet. We'll put something on the television, and say, time to try this on, just to see, will they tolerate wearing that hood set? It can be a challenge for a younger person. But, it's a clear vinyl hood with a window. We allow our patients to watch television just as well. One of the benefits that we have in a multiplace chamber is we can allow a patient to use a restroom in the adjacent entrance lock. So if patients have the need to use the facilities, so to speak, they absolutely have the opportunity to do that. So it's kind of a creature comfort afforded by that chamber system. The unique thing about a multiplace is, even though in a monoplace you'll have a nurse operating the chamber on the outside looking in, with a multiplace we actually staff the registered nurse inside the chamber. And they're there to provide for the comfort and safety of the patients who are being treated in the chamber.
Great. So one of the questions I guess I wanted to ask too, because if you can kind of visualize what this therapy looks like, for someone who might be claustrophobic, how do you exactly handle those kind of situations?
Well, So for the true claustrophobics, they just run away. But for people that are anxious, a lot of times we just use a medication like Ativan to get them through. A lot of people will only need that once or twice, because once they've experienced it, it takes the fear away. Like, oh, that wasn't so bad. The TV itself, I think, is a huge thing.
Yeah.
Because it's a great distractor. You get involved in a movie and you're not thinking about being in the chamber. And I always joke a little bit with the patients, that we've never left one locked in. We always let them out.
Yeah. I think one of the benefits of the Multiplace with regard to the anxiety with confinement is that because there's other patients having the same experience of treatment, they tend to develop this little bit of a cohort where they're very supportive of each other, as well as new patients. They talk each other up. You'll get through this. I did. And look, I'm 30 treatments into my treatment plan. That goes a long way, and we really can't discount the kind of therapeutic relationships that get established between these patients as they receive hyperbaric oxygen in a multiplace chamber. That being said, we use medication similarly, but handholding goes a long way just as well. And we're afforded that opportunity in a Multiplace to actually kind of kneel by the patient, hold their hand, kind of talk them through the difficult parts of it. And Dr. Cooper's exactly right. Sometimes just getting a couple underneath their belt is enough to establish the confidence that they can do this and do this well. And so that's how we are successful, and the patients are too.
Great. Thank you for that. So a couple questions that we have coming from our audience. Someone would like to know if a hyperbaric therapy can generate new cells and regrow tissue, such as like skin for wound healing, and if it can help to regenerate nerves in her arm that were damaged during surgery. Did you want to answer that for us?
Yeah, so I had mentioned earlier about stem cell recruitment and the body, when there's adequate oxygen and nutrition being delivered, so once we've reestablished that infrastructure, and that's the way I kind of describe it to patients, that we're regrowing those small blood vessels, we're bringing in these stem cells. It's kind of like a construction site. I can't really build the building until I've got the pipes and the electricity and the sewer and all, that stuff the infrastructure has to be there, then you can rebuild.
Yeah.
And the body will tend to rebuild, that kind of stuff. But, nerves are going to be harder than skin. And are going to be, so our experience with that is that, we don't get as robust improvement in nerves. We get some. And sometimes it's been profound, really profoundly helped people, but other times, it's been minimal.
Okay.
Skin is something that responds very well, and we've had very nice, and in fact, that's kind of a big deal, when we're talking about breast cancer, because we're talking about mastectomy wounds that may be ulcerated or non-healing, and that's what we're trying to fix.
Yeah.
And so, yeah, we get good results with that.
That's great. That's great. Nick, did you want to add to that?
There is some limitations as to how we can apply hyperbaric oxygen therapy to a diversity of medical or surgical conditions. And just as Dr. Cooper has identified, not all of them are responsive to hyperbaric oxygen. And fortunately, we do have some guidance in the use of this, and basically what we're looking at are where's the scientific evidence for its efficacy in the treatment of certain conditions, and there are really 14 indications for hyperbaric oxygen therapy for which there's sufficient clinical and scientific evidence for its use. And that really it limits some of the conditions for which we can theorize this being useful, because we do have some limitations as far as our ability to receive payment for the services we render in the treatment. There's a strong physiologic argument for its use in a number of things, but again, we do have some limitations that are imposed on us by the insurers of our healthcare that make it difficult sometimes to explore some of those other potentials. But there are certainly very good scientific evidence for any number of conditions for which this is responsive, and we can rely on good outcomes.
Okay, that's great. We have another question from our audience. What does the normal treatment plan look like? Dr. Cooper, do you want to?
Yeah, so if we're talking about radiation treatment, ordinarily we're doing 40 treatments. It would be the pat answer. 40 treatments, especially if there's a surgical intervention, we'll tend to do 30 before intervention and 10 postoperatively. And the 10 postoperatively, we're kind of doing for other reasons than what I mentioned before, other mechanisms that go to hyperbaric's ability to help with acute injury,
Okay.
Which is different than radiation effects, but trying to prevent complications from surgery, that kind of thing. So that's kind of in the case of, let's say a great example, again, with a mastectomy. So if you had a mastectomy and you got this terrible wound that isn't healing, and the plastic surgeon is going to, revise and try to close that, we would probably do 30 treatments. We would encourage to wait, get the 30 treatments in, and then do the surgery, and then do 10 post-op treatments. The treatments themselves are about 2 hours. And then, because it's kind of routine, we tend to do that, at least at our shop, and I'm guessing probably at Nick's as well, that we do it kind of Monday through Friday during, normal business hours, kind of a thing. We do emergency things, and we're staffed 24/7 for that at Nebraska Medicine. I'm guessing Mayo Clinic may be as well. But anyway, but for the radiation stuff, it's usually 40. In other cases, so sometimes you were talking about like fibrosis, where there's not really a wound. And in those cases, sometimes we do less treatments ahead of time, and then, a surgical intervention, where it's almost more preventative medicine. We know that this tissue is received radiation. We know the tissue is vulnerable and may not do well with surgery. And so in those kind of instances, we might do 20 before and 10 after.
Okay.
That kind of thing, just to prevent complications.
So about how long then are they in the chamber, do you recommend?
About 2 hours.
That's
yeah,
the 2 hour?
Yeah, it's about 2 hour treatment.
Okay.
Yeah, usually about 130 minutes.
Okay. Yeah. Great.
At least the kind of the protocol we use.
Yeah. Okay. Another question from our viewer. They wanted to know if we kind of discussed the radiation fibrosis. So that was answered by you guys. Let's see. Someone is asking, they saw in the news a woman who had radiation because of breast and cervical cancer later developed bladder issues. After having hyperbaric oxygen therapy, she no longer had pain and her bladder issues were resolved. Would hyperbaric therapy help with my pelvic floor issues related to my breast cancer treatments? Nick, did you want to take that one?
If she had similarly received radiation for the treatment of cervical cancer, we know that anytime that we're using radiation in the area of the pelvis, that we do see tissue damage similar to, the chest wall damage that you would see with radiation of the chest for breast cancer. And this manifests as radiation cystitis, which would be the delayed effects of radiation on the bladder. We see proctitis, the delayed effects of radiation on the bowel. But we also see, there are a number of structures within the pelvis and the abdomen that could be pretty profoundly affected by radiation. It makes it very complicated for surgical interventions as well. So, just as we were speaking about the opportunity to, say, offer some treatments prior to entering a surgical field, just to kind of give the tissue the kind of quality or resilience that perhaps it's necessary to heal properly, there are opportunities to do that if it's well documented. There's concerns about entering, say, surgically to repair those tissues, but also post-operatively, we get referral where the surgeons are confounded by just the quality of the tissue as they go in to make these types of surgical repairs and try and improve the quality of life of some of these patients who really are suffering profound effects of a radiation injury. And we can get involved in their care and try and do similar things that we're doing with delayed effects of radiation in the chest wall associated with breast cancer treatment. And we see a lot of that, to be quite honest. And so we also have tissue grafting that occurs. Plastic surgeons will come in and manipulate structures and take muscle and move it to cover defects and wounds and things like that. And we have an opportunity to enter the care of those patients more of an acute care, where we're really trying to help these tissues survive, where they're swollen with surgery, with the surgical intervention and things like that. So it does make sense that perhaps there are some issues if she's had cervical cancer and received radiation there. I think it would be unlikely to have those types of changes as a reflection of radiation therapy to the chest for breast cancer, though. So, but definitely if there's been radiation to that area for cervical cancer.
Okay. So you were talking about just with the treatment, for kind of how you both were discussing how it really helps with wound healing and the soft tissue. Is there anything noticeable when a patient comes out of hyperbaric oxygen therapy that they feel less fatigued, or anything where it's not physically noticeable?
I think the effects of this are cumulative for the types of the mechanisms that we're trying to leverage with hyperbaric oxygen for these types of conditions. So very infrequently are we going to have any patient report any substantive change in their condition for many weeks, really. As we observe the increased in oxygen tensions in tissues, introduced by this therapy, eventually we have budding of new blood vessels off of, existing, healthy or relatively healthy vasculature, in this angiogenesis, or the building of a new durable blood supply to these tissues. After many weeks, some patients who may have, say, be passing blood with voiding of urine associated with radiation cystitis may see some changes in that. They may see their urine clear, or they may see it actually get a little bit more. So they do start to see some changes, but it takes a good long while for these things to really be realized in a substantive way that could be reported by a patient for sure. In a surgical context, if we have somebody who has, like, say, a tissue grafting, and they come to us and the tissue looks darkened, dusky, like it's getting poor oxygen delivery. Sometimes coming out of the chamber after just that initial treatment, the tissue pinks up and maybe some of the edema is reduced in the successive hours as well. So it all kind of depends on how you're trying to use the therapy, if it's more of an acute or in a chronic sense.
Okay. So to be patient is the key.
I think so.
Yes.
I think so.
Yes.
It's a huge time investment for these patients.
Yeah.
To be able to come to us daily for 6 to 8 weeks is no small task. And to ask them to be patient for the type of physiologic changes and hopefully improvement in their quality of life is a tall order just as well.
Thanks for that, Nick. We have another question. In other states, hyperbaric therapy, oxygen therapy is normal in the treatment plan. Do you foresee this being a thing in Nebraska? Dr. Cooper?
I don't know that it's a state-by-state thing as much as it's a hospital-by-hospital kind of issue. And kind of a joke in the hyperbaric world is, that facilities that have hyperbarics, the surgeons can't live without it. And in facilities that don't have hyperbarics, they don't need it. It's kind of what you got. And so I think, as surgeons become familiar with it, they'll start using it more. And that's been my experience, is that, I'll send somebody in once and it works, and they send in a second one, and then all of a sudden that guy's sending me lots of patients. That they realize, hey, I can really help my patients out. I can get better surgical results. I get less complications.
Yes.
And so I think it grows that way. I don't think it's particularly a state or legislative type of an issue. It's just the experience of the surgeons in those communities and those hospitals.
Have you seen a growth in interest for hyperbaric oxygen therapy in Nebraska over the course of the years that you've been?
Absolutely. Yeah. When I got here, and I've only been here like 12 years, so our program was the first in the state, and it's about 30 years old. But in the recent years, like last 12, 15 years, I think there was one other place that was doing it. I think maybe it was Norfolk, Nebraska. But now there's facilities in Fremont, Norfolk, Hastings, not Grand Island. North Platte's been on and off. I'm not sure if they're up and running currently.
Okay.
But they've had the capability. And then Lincoln at the Burn Center, as well as I believe Bergen Mercy here, and then right across the river in Jenny Ed and Council Bluffs. So there's been a big expansion of it. Now I'll just ring my own bell a little bit, toot my own horn, right? Is that all those other places are doing this kind of stuff, routine wound care. Nebraska medicine is the one that stands ready 24/7 for the more complex emergencies and to do critical care, ventilated patients that are unstable. We can take care of that.
Oh, that's
great. So that's kind of our niche specialty, although, again, most of what we do is what we're discussing today, the radiation stuff.
Yeah. Great. All right, we have another question. Do you have to be recently out of radiation to use this therapy and be successful? Nick, did you want to take that one?
So really the opportunity for the use of hyperbaric oxygen therapy is for the delayed effects of radiation on tissue. There are acute and subacute effects of radiation interventions, and there's limited evidence on its efficacy. So really, as Dr. Cooper identified, it is a small percentage of patients that are going to experience these types of complications of their radiation therapy, and really we won't understand that those that their care has been complicated really for about 6 months, maybe even longer. Sometimes these tissues get insulted or injured in either with traumatic injury or surgical intervention, and then we understand that they are complicated more chronically. But acute and subacute effects of radiation, there really isn't a place for hyperbaric oxygen therapy.
Okay. Thanks, Nick. I have another question. Someone wants to know if it's true that some research has found evidence suggesting pressurized oxygen therapy could inhibit cancer growth. For example, studies show combining oxygen therapy with chemotherapy can slow cancer. Dr. Cooper, you want to answer that one?
Yeah, so there's kind of research on both sides. So first I'll share, I think what I would call the empiric evidence, meaning what are the outcomes, right? Because we can have theory all day and talk about tumor necrosis factor and inhibition of that and this cytokine, and right, we can talk about all the medical stuff like that. But what we really want to know is, does it work? Or in this case, does it inhibit cancer? Or the other question that gets asked is, does it promote cancer? Right? Because we have this angiogenic effect. And so one of the fears, theoretically, is that if cancer is present, that hyperbaric oxygen could accelerate it. And that was a big fear. So there's been a lot of monitoring for that and looking into that. And what we see is that it doesn't appear to have much effect. Some of the biochemical type research that's been done has shown both pro-cancer and anti-cancer effects. And so I think for the most part, it cancels each other out. Now there are specific tumors where hyperbarics does seem to have an anti-cancer effect in conjunction with either radiation or chemotherapy. And that is an area of research. It's not prime time, but it's an area that's still being researched and looked at.
Oh, that's good to know.
And some of that stuff's a little bit complex. For instance, for some of these tumors, for hyperbarics to work in conjunction with radiation, the radiation has to be given really within, like 15 minutes of getting out of the hyperbaric chamber. So it becomes logistically very difficult.
Okay.
It becomes kind of a big deal to try to figure that out or to provide it. So anyway, that's unfortunately I'm not doing research like that, but I know that people are looking into that, and so that is an area of interest. It's a great question.
Yes.
And I think that is a direction that hyperbarics is going to go.
That would be awesome.
In conjunction with the radiation oncologists and the medical oncologists.
Yeah, that's great.
Nick, are you up on that more than I am? Because I'm very distant from that.
No, I'm glad you took that question, to be quite honest. We've had some radiation oncologists approach us about these questions, really kind of asking, what are the logistical challenges that our facility would present to try and deliver a therapy plan like you're talking about, where you're administering hyperbaric oxygen in very close proximity to that radiation therapy. And just as you've described, it is a challenge. We've run a schedule of patient care here, and we're kind of like a train. The train has to leave the station at a certain time most days. We would have to really work in concert with a program like that to maybe offer a unique schedule to make sure that we're capturing a group of patients in just the right time. And I think that could, it is a challenge, and I think it will continue to be, unless somebody decides to really put the radiotherapy program very close to us.
Well, I'm sure it's complicated with varying cancers and different tumor markers to actually pinpoint what is the most beneficial to what cancers.
No, it's true, and sometimes we enter into the care of patients, and where we thought perhaps we would have an effect on improving their condition, we understand that we're not, and that actually is an opportunity for us to approach that medical team and ask, do we have active cancer that maybe is confounding the therapy? So you have to think about the potential for recurrence with some of these patients. So
yeah. All right. Would my oncologist recommend this therapy? Who would like to take that one? Dr. Cooper?
Sure. Well, your oncologist is certainly welcome to. The majority of the referrals that I get for this kind of stuff, well, I get some from radiation oncology, but really it's more the specialists involved with whatever's not working right. So in other words, like for these mastectomy things, it's usually going to be the plastic surgeon who's trying to repair the wound rather than the oncologist or the radiation oncologist. It's going to be the plastic surgeon, or the radiation cystitis. That's going to generally be from a urologist. So it's usually whatever organ has been affected, that specialist will usually be the one contacting us,
Okay.
or recommending. That it's not 100%. Sometimes, you'll have somebody, like with the mastectomy wound, and the radiation oncologist will be the one who suggests it. But more typically, it's the surgeon.
So would you say a lot of the oncologists now are sort of on board with using hyperbaric oxygen therapy? Have you seen an increase?
I think mine are.
Yeah,
But
yeah.
like I said, I think it's almost hospital specific.
Yeah.
Like what the culture is, whether they're aware of it, and awareness is a big thing. People just kind of don't always know about it, and by people I mean like doctor people.
Yeah.
And even at my med center, I'll run into people all the time. They're like, "Oh, do we have hyperbarics?"
Really?
Yeah. "Oh, do we have hyperbarics?" I go, "Yeah, for the last 30 years." And they're like, "Well, where is it?" I mean, we're kind of like the best kept secret in the hospital.
Yes.
We're kind of tucked away, and people don't know. And I think that happens, where it's like out of sight, out of mind. People just don't even think about it. There's not a whole lot of education about hyperbarics in medical school, or really even in residencies. Most of that tends to be for emergencies like carbon monoxide poisoning, gas embolism, those kind of things, where you're kind of made aware that in an emergency this is who you'd want to go to. But I don't think it's routinely taught. And so really that's kind of a big part of my job. And when I was brought in to my position here at Nebraska Medicine, hyperbarics was on the private side of things, and I'm an academic emergency physician.
Okay.
And so when I came on board, they were like, "You need to make the university docs aware, and you need to promote." So a lot of what I've been doing is promotion, kind of as educational, which even this is sort of some of that. But for the most part, I try to make the rounds of different specialties and say, "Hey, can I come talk to your people about what we have to offer, how we can help you and your patients?"
That's good.
Yeah.
That's great. I feel like it's good to let these patients know and survivors know, like, this is an option. Maybe discuss this with your oncologist, see what they say about it. What do they think?
Yeah, absolutely. The other people I like to talk to, and I don't know if you've had this kind of experience, Nick, but I've had great results from talking to nurses.
Okay.
So I've talked to like AORN and the CCRNs, the critical care and the operating room nurse organizations.
Sure, yeah.
And because they're like, hey, why don't you, they tell the surgeon,
Yes.
right? They tell, hey, wouldn't this be good for hyperbarics? And the surgeon is like, oh, that's a good idea, and I get a consult. So that's actually had a lot of bang.
It is.
Yeah.
It is the knowing that it's
Yeah,
an
it's just getting it
option.
out there to people, put it in their heads, and
Yes.
because really that's the thing. It's people don't need to know that hyperbaric's going to work. They just need to know to ask the question. Hey, we're going to ask hyperbarics, because I tell people no a lot. I get a lot of consults. It's like, yeah, I don't really think it's going to fit this, right? But I'm glad that they ask.
Yes.
Right?
Yes.
I'm glad you're thinking about it. Keep sending. Call me anytime.
It's
That
best to ask than to not know at all.
Because there's a lot of things it does work for. Like Nick said, there's 14 or 15 things, and there's some stuff outside of that, and there's probably some stuff outside of it that it does work for, but we haven't really approved yet in the sense of being able to get it paid for or have scientific rigor. And then there's stuff that we just don't know, and there's stuff that's probably just kind of BS, right? That it probably just doesn't work for, and sometimes it gets sold. Unfortunately, there's a fair amount of hyperbarics going on as alternative medicine, and being sold as a panacea, and that kind of makes people pretty skeptical, makes mainstream doctors pretty skeptical of it. And so I have to fight that, and I'm sure Nick does too.
Yeah, I didn't understand that as part of the job when I took it.
Yeah.
I came to the nurse manager role as a critical care nurse. From administering those critical care treatments in the chamber, and I saw it work with these acute cases. I was and so I became an evangelist for it on my own medical ICU unit, where I would make recommendations, and all the other supplemental ICU nurses would do similarly. We'd say, we've seen this work, in similar, and ask the question, submit the consult. It's absolutely the truth, and I will gladly sit and talk hyperbaric with anybody who will have me, and I regularly have rotations of even physical and occupational therapy students within the Mayo Clinic School of Health Sciences that rotate through, because I know one of them will hear something that we discuss, or when they tour our facility, they're going to take something away and they're going to pass it along to somebody. And there's a lot of mystery about what hyperbaric oxygen therapy is, how it's administered, and there's a tremendous amount of misinformation. And so being able to impart accurate, reliable information about this therapy and its use is a great service, not only to our medical institutions, but our communities in general. And unfortunately, people ascribe a naturopathic quality to oxygen. The doses we're administering it are well beyond what you're going to encounter otherwise outside of a hyperbaric chamber. And so, there's been a lot of off-label use and things for which it's inappropriate. There's no evidence-based, and they happen to often be conditions for which there's not a good treatment. And so, they look at us as an opportunity maybe to make a change in their experiencing of illness, if not their own, then their loved ones. And that's been complicated. And there are some within the medical community that look at us to some degree as snake oil peddlers because of it. And that's unfortunate, because this is a beautiful therapy if applied correctly. And it can make a tremendous difference in people's experience of health.
I think you sort of touched on this, both of you, but one of the questions we have is, what is the pressure? I think Dr. Cooper touched on this, but wanting to know, what is the pressure of the hyperbaric oxygen therapy in order for it to be therapeutic? Did you want to?
Sure.
kind of touch on that again?
So I would say there's a little bit of debate out there, and more importantly, there's probably a lack of great, well done research on the ideal thing. But my understanding, the kind of the consensus of the experts, is that we use 2.4 atmospheres, which is 2.4 times normal air pressure. I'm not quick on the math to come up with the PSI for that, but about 2.4 is what we use standard for our treatments for radionecrosis. Now we use some different pressures for some emergency things.
Okay.
We go a little higher.
Okay.
But 2.4, and I know Dr. Marks and Dr. Feldmeyer, who are national leaders in radionecrosis treatment, they came out very strongly that 2.4 atmospheres was the right answer a couple of years ago, and they said if you were going to use less, then you have to do longer treatments to make up for that. And sometimes we do use less because of patient intolerance kind of thing.
Yeah, that makes sense.
Yeah.
Nick, did you want to add as far as how?
Yeah, I completely agree with Dr. Cooper, and having a monoplace facility, to be able to apply that 2.4 standard that Dr. Marks and Dr. Feldmeyer certainly have communicated to be most optimal for patient outcome is the ideal. When you operate a multiplace facility like we do, you have a chamber that's pressurized with air as opposed to oxygen. And although the patients are breathing 100% oxygen, the nurse who's inside is breathing the compressed air, just as a scuba diver does. Instead of wearing a compressed air tank on your back and breathing it like a scuba diver, we actually breathe inside the tank. And our program years ago established a standard of 2.0 atmosphere absolute for our standard treatment, because it seemed to offer the greatest balance of risk reduction to the occupant caregiver, being the registered nurse, and the clinical outcome of patients. It just happens to be an occupational hazard of a nurse to work in a multi-place chamber that we can get decompression sickness, what is more popularly known as the bends, are observed in scuba divers. We're just dry divers is what we are, but it's a real risk, and so we certainly administer treatments well beyond 2 atmosphere up to 3 atmosphere depending on the condition. But our standard treatment profile for most conditions, especially the volume of patients that we're seeing, is just 2 atmosphere absolute, twice the pressure you and I are experiencing right now. It's about 33 feet of seawater equivalent.
Okay.
And I will say, in support of that, because I don't want to make it your way versus my way.
Yeah.
There is some data to support 2.0, and I know that there's at least one national leader that espouses that. So that's what I was saying. I don't think we've fully answered it. We've got some, leaders in the field, and some say 2, some say 2.4. So my boss, when I was hired, so the chairman of emergency medicine, he had nothing to do with hyperbarics, but he was always joking with me that the only decision I had to make in my life in hyperbarics was 2 or 2.4.
That's great.
That's the hyperbarics in a nutshell.
Well, similarly, there's the number of treatments too. And, the standard care plan for delayed radiation injury, as Dr. Cooper identified, is 40 treatments, if you're observing 2.4 atmosphere. But, that becomes a double-edged sword. I'll be quite frank, because when you have, surgical referrals to you, and you have, you settle on a treatment plan, maybe initially we're gonna do 20 treatments, and we're gonna see how they respond, and then we'll decide whether we're gonna do additional treatments. Both the patient and the surgeon tend to get fixated on the number, and that does a disservice to the therapy, because really we want to treat to a clinical response. With a diabetic foot wound, we don't really expect it to completely resolve or heal over during the time that you're with us. We're going to promote those angiogenic effects. We're going to regrow that durable blood supply that over time will provide for the ultimate healing of the wound. So you may leave with a small wound still, but we've set you up for success. And sometimes that's difficult, because we want the gratification of having seen something close or be resolved completely. And that's not always the reality of what we do. And so, work collaboratively with your hyperbaric medicine provider and decide on a good place to start, or go all in on 40 and see how you respond. And maybe you need more, maybe you need less, but really it should be, what's your experience of the improvement of your condition, or the continued need for improvement that informs whether you have additional or fewer treatments.
Thanks, Nick. That's great to know. All right. I don't think we have any other questions. You guys, I think, answered everything for everyone, and we really appreciate all the great information and knowledge that you guys shared with us tonight. So Project Pink's mission is, from the moment of diagnosis through end of life, to provide the tools and resources and a strong network to strengthen the mind, body, and spirit of breast cancer survivors. We hope we were able to do that for you this evening. This will also be posted on our YouTube channel if you would like to go to see it in the recorded version. And then please remember to check out our website, projectpink.org, for upcoming events. Thank you, Nick. Thank you, Dr. Cooper.
Thank you.
Thank you both.